check up the first suspected anemia during pregnancy.
I would like to request Dr. Monesh Tomar kindly start the discussions for our student.
We all know echocardiography is one of the main arm of the stool if we think from the examination of a child with congenital heart disease. It is clinical examination including history and physical, then X-ray, ECG, and now it is the echocardiography. Why echocardiography is important and how we should go for the echocardiography, which is we are going to discuss in this session. By echocardiography, in present scenario, we have very advanced echo machine. We can get very good quality images and have excellent resolution. So overall, delineation of anatomy is very good with the present echo machines. And by echo, we can make out the correct hemodynamics, which is very important in taking the decision whether we have to go for the follow-up, whether we have to go intervention, surgical, or the catheter intervention. That everything can be decided by the echocardiography. It is a prompt, non-invasive diagnosis. By defining anatomy, cath is needed only for the hemodynamic assessment whenever there issue of the pulmonary arterial hypertension. Otherwise, it's only for the intervention. So need of cardiac cath for the diagnosis has decreased a lot into this scenario. By echo, we can do repeat echo examination. So follow-up is easy. Plus, by that timing of intervention can be defined. We can do assessment in the pre-op, peri-op, and the post-operative period. Plus, post-intervention period. And today, fetal echocardiography is there, so diagnosis now starts in the fetal life. Complex heart defect, which is not amenable to surgery, can be defined the fetal echocardiography, and family accordingly can be counseled. What is the basic of echocardiography in the congenital heart disease? We all know echo is an observer-dependent investigation. If you know, your mind know, your eyes will see. So it is very much dependent on your knowledge. So clear definition of the congenital heart defect should be in your mind while you are doing the echocardiography. For accurate echo, the observer should have an excellent understanding of normal and abnormal cardiac anatomy and physiology. So what is normal in fetal echo? What is normal after birth? This transition circulation in the later age group. What is the pattern in changing hemodynamics? We all should know to say it is abnormal or it is normal. And we should follow a systematic approach whenever we are doing a pediatric echocardiography. It is almost in contrast to the adult echo, where we mainly have to see the function, valve condition, regional wall motion abnormality. But in the congenital heart disease, it is you have to go by the systematic approach, starting from the situs, then AV connection, then VA connections, and then the defects. Why we need systematic approach? Because you will do a more accurate evaluation. If you jump from subcostal to apical to suprasternal views, or you go to start directly seeing, suppose patient referred as a VSD, you just focus on the VSD, you can miss a lot of things associated with VSD, because any combination abnormality can occur in the congenital heart disease. So you have to rule out all the things before labeling, before giving your conclusion. So you can have more accurate evaluation, you will have easier understanding of the images. Plus, when you go systematic, any other person reviewing your echocardiography can make inference or conclusion from your recorded images. Then comes after this basic come the planes. Our body has three planes. One is the sagittal plane, then the coronal plane, and the axial or the short axis plane. These planes, long axis plane means sagittal plane, cut the body in two halves, and Then the short axis or the axial plane, it is just perpendicular to the long axis plane, and the 4-chamber plane or the coronal plane. These planes are related to the heart, not to the body, because in the body our heart long axis is obliquely placed, so it is definitely not in long axis with the heart. Body long axis is this way, while the heart is placed obliquely. So these planes are related to the heart. And why these conventional planes are not useful for the heart? If we go directly, if we take body sagittal plane, body coronal plane, body short axial plane, these are not useful to the heart, not applicable to the heart, because heart is asymmetric located. Okay, that just I told you. Then heart in itself is asymmetric, because LV and RV are not in a direct anteroposterior or side by side relation. They are sort of wrap around each other. This is left ventricle, this is right ventricle. So we cannot go by the one plane. We have to rotate the plane against the body axis. We cannot put probe directly, it is the body short axis, so we should get a cardiac short axis view. It is not possible. In the fetal life or in the neonatal period, heart is mainly horizontally placed. Means body long axis and heart long axis is just perpendicular to each other. So like it is, while in the adult, heart is more of longitudinally placed. So body long axis and the cardiac long axis is almost same. So you cannot go by the body axis, because heart position changes in the fetal or in the neonatal, it is almost horizontally, then it rotates and come almost to the long axis in the adult patient. So your axis, your probe position should be according to the cardiac axis, not according to the body. You have to change position of the probe according to the images. And from these planes, longitudinal, coronal, subcostal views, you have to sweep the transducer and tilt the transducer to take detailed images in the different planes. These are the cardiac planes. This is the long axis, means the sagittal plane across the heart. Then this is the coronal plane, this C is the coronal plane, and this B is the short axis plane, which is just perpendicular to the long axis plane. And these are the planes for the great vessels. Great vessels are more of symmetrically located. So after emerging from the heart, the aorta and the pulmonary artery has a fixed position. They are wrapped around each other. So you can make a fixed plane around the great vessels, but to the main body of the heart, you have to have a different planes. And we know that now come to the windows. We know the heart is sitting in the between the lungs. It is from all around surrounded by the lungs. In the fetal life, lungs are filled with the water, so you can get window through the lungs. While in the after birth, lungs are expanded by the air, so you don't have windows from the chest. You have very limited space from the subcostal, suprasternal, parasternal and the apical view, from where you have to get the images. So we have very small space in between the lungs from where we have to define the heart. And these windows are obviously in the pediatric, subcostal window is very important. We take most of the information from the subcostal window, while in the adult, for that we require the transesophageal echocardiography, as our windows are not good. So subcostal window, which is very important, plus very definitely luckily available in the pediatric age group, in which we take the sagittal section and the coronal section of the heart. Then the apical, then parasternal long axis and the short axis, and the suprasternal windows. So this is our body. We have only 4 windows. This is subcostal, which is very important in pediatric. Then the apical, then parasternal, short axis, long axis according to transducer position, and the suprasternal. We have only 4 windows available for us to define the echocardiography. If these windows are not adequate, we have to go with the transesophageal echocardiography.
Like ma'am, you said in the neonate and fetal life, heart is more like horizontally placed. So if we take from the subcostal view, it is going to be like perpendicular to the axis.
So transducer position slightly needs to be modified.
Yeah.
And same is application in the chest X-ray. Like chest X-ray, we say cardiomegaly more than 60% in the neonatal period.
Yeah.
It is because heart is horizontally placed. It is not because heart is enlarged in fetal life. So ratio is same. Heart and chest thoracic ratio means practically it is same, but because heart is horizontally placed, your so dimensions means ratio in that particular axis will be different than the later age group.
So all our students should remember this very aspect, because when they are going to practice, it is one of the important issue.
Then we start investigation echocardiography from the subcostal view. This is the subcostal view. Subcostal view, transducer is kept just horizontally here. at mark 3 and pointing towards the marker is towards the left of the body. So this short axis, the transducer is placed in the short axis plane in subcostal area, and we have to, from here we have to define the situs. So before starting congenital echo, we have to know whether it is situs solitus, situs inversus or situs ambiguous. Okay, so situs solitus means this is short axis view at the level of abdomen. This is red one is the aorta, blue one is the IVC, means aorta is towards the left, IVC is towards the right. When we look further, we get stomach towards the right, and here we'll see liver towards the right, and here we'll see the stomach bubble. So situs solitus means left sided structure on the left, right sided structure on the right. Then come the situs inversus. In situs inversus we see totally opposite thing, means IVC towards left, stomach bubble towards right, aorta towards right, and the liver towards left. This is the isomerism. These two things are the ambiguous. Ambiguous when we don't follow the usual situs solitus or situs inversus. Here the symmetry has lost, asymmetry has lost basically. So left isomerism means body structure are of left sided. Right isomerism means right sided. Here in left isomerism we get a central liver lobes on both sides of the spine, aorta in the center, IVC, because IVC is a right sided structure, IVC we usually get interrupted. So posterior venous channel, which is azygous or a hemiazygous, we continue to the heart. While in the right isomerism, because right isomerism again we get central liver, aorta in middle, and IVC will be present, which continue to the atria, whether it is left sided place or the right sided place. So we before starting to the cardiac anatomy, we have to define the situs. Usually abdominal situs and atrial situs are in concordance, but discordance can occur at that level also. So we should know while going to the cardiac, before defining here situs, we should be aware that discordance can occur at higher level also. Then you start examination from the subcostal plane, in the sagittal plane and the coronal plane. In the sagittal plane, transducer is kept in a vertical position, and you have to sweep from the right to left. Your transducer rotate from the right to left. So this is your heart, your transducer is here in the subcostal area, and this is the most right structure. Then you sweep 1, 2, 3, and you get the different planes of the heart. Most right will be the atria, interatrial septum. In the sagittal plane you get SVC connecting right atria, IVC connecting left atria. So bicaval view. This IVC connecting atria is very important because suprahepatic portion of the IVC define the right sided atria, morphological right atria, not right sided atria, morphological right atria. If it join to the left atria, it will be morphological right atria on the left side. So you have to define where IVC is going, to the left sided atria, to the right sided atria, to the floor of atria. So this suprahepatic portion is very important. This Eustachian valve is very important, which we have to see in the sagittal plane in the most right stage. Then SVC joining right atria, and here you will see right pulmonary artery in short axis and the LA. Here another thing which you see is the foramen oval. If it is patent, flap of the foramen oval. Flap of the foramen oval is always towards the left atria, so it defines the left sided atria. Then as you tilt the as you sweep towards the left, you will find aorta coming from the left ventricle. Then you define right ventricular outflow tract, and then the ventricles in short axis. In all these view, ventricle septum come in plane, and you will look for the VSD if it is there. So this is the echocardiography images of this two line diagrams. So this is SVC, IVC joining the right sided atria. Then this is the hepatic vein joins inferior vena cava, then left atria. Here this is the flap which is pointing towards the left. So this is morphological left atrium, this is morphological right atrium, which we have to define while going into the heart. At the same level we also define two appendages, because atrial appendages are the most consistent feature of the isomerism of the situs. As you go further left, you will find both AV valve in short axis and aorta coming from the left atrium, left ventricle. And then you get right ventricle outflow tract. This is right ventricle, pulmonary valve, male pulmonary artery. This is LV. You can see discrete papillary muscle, which you see in the adult in parasternal short axis view. These are very important to define left ventricle. And here you see smooth wall of the left ventricle. Interventricular septum on LV side, it is very smooth. On RV side, it is rough. So trabeculation on the RV side. These things you have to look simultaneously. Means you are going to define it is left-sided, right-sided thing. Then morphologically it is left-sided left, right-sided right. So at all level, if suppose there is discordance at the level of atrioventricle, here you will get right ventricle, morphological right ventricle on the left side, and here you get morphological.
I think to understand all these things, their basic anatomical knowledge has to be very good.
Morphology different identification is very important. Not the left-sided, right-sided structure. You have to know this is left atria, morphological left atria. This is morphological right atria. This is pulmonary artery. Why it is pulmonary artery? Because like PA, we identify by the bifurcation. After origin, pulmonary artery bifurcate. Coronary arises from the aorta, but coronaries are not a consistent feature of the aorta. Like anomalous origin can occur. So you cannot go by the coronary artery. You have to go by the anatomy. This bifurcation. Aortic arch branches. Pulmonary artery do not make the arch. So these things means why it is pulmonary artery, why it is aorta. You cannot go by the coronary. You have to go their further features. Then as you go further laterally, you will get the ventricle in short axis and the apical part of the ventricular septum for the ventricular septal defect. And you are going laterally lateral to screen the further area of the ventricular septum. From the subcostal sagittal view, we come to the subcostal coronal view. Coronal view means long axis view. Okay, you keep the transducer flat in the epigastric area and then turn it just anteriorly from after taking the short axis view. As you turn anteriorly, here you see from posterior to anterior. In the sagittal, the sweep was from the right to left. Slowly you are going right to left. But here you are going from the posterior to anterior. Most posterior structure is, is the coronary sinus. So you will get this view. Means coronary sinus forming the floor of the left-sided atria. As you go anterior, you will get subcostal four-chamber view. Then you will open the aorta. And pulmonary artery is the most anterior structure, then you get the pulmonary artery. So most posterior coronary sinus, then AV valves, then aorta and the pulmonary artery. From anterior to posterior you will scan all these things.
Ma'am, here one thing what I would like to ask is, suppose there is a like aorta, most of the time it is arising from left ventricle. In case of like tetralogy, it is arising from the overriding like right ventricle. So how a person is going to be identified, like just seeing this aorta, the right ventricle may be assumed that it is a left ventricle. So it may be matter of confusion. So how this kind of confusion can be avoided?
Like as I told, the foremost thing is to identify the chamber, not by the sidedness, by the morphology. We have defined solitus, situs solitus. Then we have defined this is right atria, this is left atria, one by the IVC, then the appendage, then the flap. These things identify the atria. This is left-sided atria, this is right-side, morphological LA, morphological RA. Then you come to the AV valves level. I will tell that sequential analysis after this. Then you come to the level of AV valve, means this is mitral valve, this is tricuspid valve. You have to define which is mitral, which is AV valves goes with the ventricle, which we know. Okay, mitral is connected to LV, tricuspid is connected to RV. Whenever there is discordance, tricuspid will become the left-sided valve, mitral will become the right-sided valve. So it goes with the ventricle. Tricuspid have multiple papillary muscle attachment, while mitral has discrete two papillary muscle. Then my tricuspid valve is a septophilic valve, means attachment has to the septum. Then tricuspid valve is more apically placed than the mitral valve. So by these things you will identify tricuspid, mitral and the right ventricle, left ventricle. Then you open the great vessel. You are seeing two great vessels. Okay, so in one view you are seeing two great vessels arising either concordant, discordance, double outlet, whatever, but two vessels. You will say this is, I am seeing two great vessels. Then you have to follow them entirely.
Okay.
Further, you have to define their course, whether it is going to form pulmonary artery, going to form the aorta. Only at the level of valve you cannot see it is aorta, it is pulmonary artery. Anything can occur. In congenital heart disease, anything, double outlet right ventricle, double outlet left ventricle, VA concordance, VA discordance, atresia, single outlet, truncus. So there's so many variation. You have to follow the great vessel. It is going to form the aorta, it is going to form the pulmonary artery, which is hypoplastic, which is dilated, then further coarctation or PDA join the system. Okay, so in the subcostal coronal plane, it is like the apical four-chamber plane. You start from the posterior plane and goes anteriorly to define the posterior anterior structures and relationship. So this is 2-dimension echocardiography. Subcostal coronal view. This is left atrium, right atrium. This is right upper pulmonary vein joining left atria. It is very important to define here pulmonary veins. This is right upper, and here you will find left lower pulmonary vein. Aorta, descending aorta always goes with the left atrium. So in the fetal echo, we identify LA by the descending aorta. Additional feature, descending aorta is, suppose it is situs inversa, descending aorta come to the opposite side.
Opposite right side.
So this is started descending aorta, and as I go anteriorly from that plane, this is left atria joining left ventricle, right atria joining right ventricle. This is a smooth ventricle. In short axis, we had defined a discrete papillary muscle of the left-sided ventricle, and this valve attached at this level to the papillary muscle. There is no attachment to the ventricular septum. As you go further anteriorly, very clearly you define the aorta, and this is forming arch. Okay, so this is definitely not a pulmonary artery. This arch you have to define. Coronary is seen here. Obviously coronary is not a fixed feature of the aorta. It can arise from the pulmonary artery, but it is seen here. Then you have to define this course and origin of the great vessel, branching of the aorta. Okay, so this is left ventricle, right atria. Further anteriorly, this is right ventricle and right ventricle outflow tract. Here you can see the moderator band, rough septal trabeculations, smooth LV site. Okay, so anteroposteriorly you have identified structures. Anomaly can occur at this, suppose malpose great vessels. Posteriorly you will find pulmonary artery, anteriorly you will find aorta. And with malpose great vessels runs parallel to each other. Usually they don't cross each other. Here we get saucer's appearance in the short axis view. But with the malpose great vessels, we don't get that view. Great vessels run parallel, means aorta and then pulmonary artery parallel to each other. As I will show you the pictures of the malpose great vessels. Now come the apical four-chamber view. Apical four-chamber view, again we scan from the posterior to anterior plane. Transducer is at the level of the apex. We feel the apical impulse and put the transducer there, marker pointing towards the left. Okay, and from that we look posterior, where we find the most posterior structure is the coronary sinus. Anteriorly we get the four-chamber view, and further anterior we get the five-chamber view, that is the aorta arising from the left ventricle. Further anterior we get the right ventricular outflow tract. So again anteroposterior scanning at all levels we see which is left-sided thing, which is right-sided thing, means morphologically morphology we have to define. Here in the four-chamber view, we look for the attachment of the mitral valve, for the tricuspid valve, identify the right ventricle, left ventricle, and the concordant or discordant connections. This is echocardiography picture of in the apical four-chamber view in most posterior planes. This is right atrium, right ventricle, and coronary sinus forming the floor of the left atria and the left ventricle. As we go anteriorly, we can very well see LA, LV, RA, RV. This offsetting is very important, means tricuspid valve is apically placed, mitral valve is higher placed, then attachment of tricuspid valve to the septum, and again same things. Define the morphology of the right ventricle. Then five-chamber plane come, where aorta arises from the LV, and in the next further tilt we get RVOT in this plane. So these vessels are crossing each other. Aorta is going this way and pulmonary artery crossing the aorta. You can see this is pulmonary artery and aorta was in this plane. So these are crossing each other. This crossing is very important to say normal connections. Then comes the this short axis will come to the parasternal long axis plane. In the parasternal long axis plane, the heart is scanned from the left parasternal area, usually third, fourth intercostal space, and the transducer is placed in the way that it is pointing towards the right. This is the only view where we keep the transducer pointing towards the right. Rest in other things it is pointing towards the left. So with a long axis we cut the plane from towards the right to the left. Most right thing is the tricuspid valve RV inflow. So parasternal long axis view, and when we tilt towards the right we get the tricuspid valve joining the right ventricle, basically inflow. Then come the proper long axis view, which you all see in the adult patient. That is my tricuspid, LA, mitral valve, LV, LV outflow, and the aorta. Then above that is the right ventricle. Here we see the perimembranous VSD, if it is there. Here you see the overriding of the aorta, which is important. If there is any perimembrance, large perimembrance, non-restricted perimembrance VSD, you get overriding of aorta. So overriding of aorta doesn't mean patient is going to have the tetralogy of Fallot. Overriding is just feature of the large VSD. Okay, and obviously DORV and connection discordance type of thing. With non-restricted perimembrance VSD, posteriorly placed great vessels overrides the septum, whether it is pulmonary artery or aorta, because in TJ here you will get the pulmonary artery. Okay, so pulmonary artery again you have to define it as pulmonary or the aorta, and you will get overriding of the pulmonary artery here. So, and further anterior tilt from parasternal long axis, you will get the pulmonary artery arising from the right ventricle. This is echocardiography of the same. This is parasternal long axis view, most posterior plane. So right ventricle inflow you are getting here. This is RA, tricuspid valve, and the right ventricle. This is proper long axis view which you see. Left atrium, LV, aorta, RV. If it is malposed great vessels, aorta normally run in a ascending tube in this way. While if it could be pulmonary artery, take a downward course, arising from the LV and take a downward course, which is a feature of the transposition of great vessels. So these small things, whatever view we are taking, we have to take information from that view. What is structure running here? Most anterior plane from the parasternal long axis, as we tilt the transducer anteriorly, we get right ventricle, outflow tract, main pulmonary artery. Again you will see the great vessels are crossing. Aorta in this vein, in this plane is just parallel, while the pulmonary artery arising from the right ventricle and cross in this plane. So great vessels are crossing each other. This. Okay, behind this is the aorta. Parasternal short axis view is just at the 90 degree, we rotate the transducer from the parasternal long axis 90 degree towards the left and get the parasternal short axis view. Parasternal short axis view mainly we do for the it's for the great vessels relation. In the short axis we get wrap around of the great vessel, that is aorta in center. While we are looking at the aorta, we have to look for the cusp, aortic valve tricuspid is there or not, or abnormal number of cusps. Then we look for the coronaries, right coronary, left coronary from the respective sinuses, and in the short axis this is right ventricle, tricuspid valve, RV outflow, then the pulmonary artery which bifurcates. Then we sweep downward, we'll get LV, right ventricle, both ventricles in the short axis at the level of valve and then at the level of the papillary muscle. So sweeping is very important. Mitral valve has to be looked in the short axis, cleft is there or not, MR is through the cleft or through the commissure. So any abnormality of the mitral valve can occur in congenital heart disease. Simultaneously we have to look out for these abnormalities. So short axis is important. With the malposed great vessels you will get malposition of the great arteries, which I will show you later. So this is parasternal short axis, this is aorta in short axis, pulmonary valve very well seen. It is dilated pulmonary arteries because it's case of the VSD. And this is RV outflow. Here is the left main coronary artery. It is very important to define the coronary artery whenever doing echo of the congenital heart defect. Whatever the congenital heart defect, you have to rule out L kappa, because with the PH physiology, when pulmonary arteries are hypertensive, with anomalous origin of left coronary artery, you may not get features of the decreased coronary blood flow, because blood flow is getting from the pulmonary artery to the coronary artery. As we close the defect, PA pressures used to fall and child can go into the severe ventricular dysfunction, because now coronaries are working under the low pressure. So whatever congenital echo you are doing, you have to define the coronary by the 2 dimension and the color. With the color, that there should be a red flow in this. If it is anomalous origin, you will get a blue flow in. Blue flow means flow coming from the right coronary artery through the collaterals to the left and then going to the pulmonary artery. So you have to look by the color, 2D and the color, both are very important. Then transducer is tilted downward. You will see LV in short axis with the papillary muscle, ventricular septum, muscular part of the ventricular septum, and pulmonary artery definitely should be looked by the color for their flow pattern. And then slightly higher level, transducer should be kept at the slightly higher level, tilted toward the left, towards the right, to look for the patent ductus arteriosus, which we call it as PD view. From the parasternal views, we go to the suprasternal, and at all level we have to keep on defining which structure is joining which chamber, what is the morphology of the particular chamber. Here we are till now we are talking only on the two-dimensional echocardiography, what we are seeing. Now come to the suprasternal long axis view. Long axis, the transducer is capped in the suprasternal notch. Child neck should be extended. We keep rounded below the neck to keep the neck extended. And in the extended neck, we require extended neck because we have to make a space in the suprasternal area. Then transducer position is the marker towards the left, and it is obliquely placed towards the left and the right iliac fossa. So this is the direction of the transducer. From there we have to take a long axis view. Long axis means we are opening the ascending aorta and the descending aorta. In the anterior plane we open the ascending aorta, whole of the ascending aorta. As we till posteriorly, means plane 2, we will find the arch and the descending aorta plus arch vessels. Under the arch we see in short axis right pulmonary artery. So this arch vessels are very important here to define, because arch vessel anomaly means vascular ring can be a cause of respiratory distress. Intracardiac anatomy normal, child with respiratory distress, we have to rule out arch anomalies. Anomalous origin of the subclavian artery, double aortic arch, or right aortic arch with aberrant origin of another great vessel. So we have to rule out the vascular rings before labeling a child normal echocardiography with respiratory distress or dysphasia. Child can present with the dysphasia, respiratory distress, recurrent chest infection. From this view, we tilt the transducer in a parallel plane, suprasternal long axis view, suprasternal position, and we get the short axis view. In short axis view, what we get is the aorta in short axis. This is a transverse arch. Then right pulmonary artery we get in long axis, beautifully seen in this view. This view is very important to take the measurement for the branch pulmonary arteries. At the hilum we measure the great pulmonary artery. Then below that is the left atrium. Left atrium receive all 4 pulmonary veins. This is right upper, this is right lower, this is left upper, this is left lower. So we call it a crab view. In the suprasternal short axis view, LA receiving all 4 pulmonary veins. This view is very important to look for the pulmonary venous connection. And the innominate vein, left SVC, right SVC, so or aberrant pulmonary vein joining the innominate. From this view we get all these information. Then defining this structure means we should know this basic, how to go for the echocardiography. Till now it was the just to give you information about how to go for the echocardiography in congenital heart disease, starting from the subcostal view, then going to the apical view, then going to the parasternal view, then going to the suprasternal view. Why we call it left atrium, why we call it right atrium, why it is left ventricle, why it is right ventricle, why it is pulmonary artery, why it is aorta. So all these 3 level of connection we should know before going to do a congenital echocardiography. Whatever the patient, it is cyanotic or acyanotic, we should know this. Why we are labeling
these are the basically basic things. Without doing all these things, things cannot be complete.
You cannot proceed in a congenital heart disease. You should know how to go. Then come to the why it is this chamber or why it is that chamber. So that again is equally important. We have to go by the sequential analysis as I described, starting from the subcostal, then to the suprasternal view sequentially. And doing all this, we should know morphological identification of the chamber or the great vessel. The atria we have to identify it as right atria. Situs we know it is, suppose it is situs solitus as I told you. Discordance can occur at the level of abdominal situs and the atrial situs. So atria you cannot imagine, suppose it is abdominal situs solitus, it has to be atrial situs solitus. That thing cannot be imagined in the congenital heart disease. Whatever we are seeing, we have to label it. So most of the time, very frequently we get the echo report of TJs, the DTJ report mentioning only DTJ. DTJ means aorta is right and anterior. It can occur in the corrected TJ, it can occur in DORB, it can be in the complete TJ. So we have to define the anatomy: atrioventricular concordance, ventricular-arterial discordance, aorta position is this, whether there is ASD, VSD or PD. So these labeling at all level is very important before giving the echo report in a congenital heart defect. You cannot just write DTJ, intact ventricular septum and the total. This you cannot go by this. So Morphological identification of chamber or vessel is very important when you are going for the echocardiography in the congenital heart disease. Fixed landmarks, we have to use fixed landmark. Variable landmarks we cannot use for identification of particular chamber. For atria, appendages are taken as a fixed landmark for atrial identification. Right-sided appendage is a broad appendage with pectinate muscle inside, while the left-sided appendage is sickle-shaped and it is a smooth-walled. This left and right appendage we should identify. Then the PFO flap, I showed you in that picture, has to be towards left atrium, means LA is identified by that, plus appendage. Then suprahepatic portion of inferior vena cava will join morphological RA, whether it is on the left side, whether it is on the right side. So it is the identification mark for the right-sided atria. Then the coronary sinus form the floor of the left-sided atria. If it is isomeric heart, suppose right isomerous, coronary sinus is a left-sided structure, you will not get the coronary sinus. So in isomerous, your identification criteria will be fixed things like appendage. You will not get coronary sinus to identify the left atria, because coronary sinus is a right-sided structure, we will not get in the left isomerous. So these things are very important whenever we are looking at the situs solitus inversus or the isomeric heart. In isomeric, we have very limited things to identify the structures. Then comes the ventricles. We know valves, AV valves goes with the ventricles. So by tricuspid valve we identify right ventricle, by mitral valve we identify the left ventricle. Plus in RV I showed you coarse septal trabeculation, while on the LV these are smooth. Septophilic tricuspid valve, moderator band, apical attachment of the tricuspid valve. These are the fixed things we have to look to identify this is right ventricle. Then on the LV I showed you two discrete papillary muscle, a smooth walled septum, and septophobic mitral valve. Mitral valve normally does not have any attachment to the septum, but rarely it can also occur. Okay, so that is not very fixed criteria, but still two discrete papillary muscle and smooth walled are more important criteria to identify the left ventricle. So this is situs solitus, means just we are going, because here we are going sequential analysis in a patient with the situs solitus. We have to define by the situs. This star is the spine. This is the spine, this is IVC, this is aorta, this is liver, and these are the hepatic veins. Then IVC joining morphological right atria, this is liver, below that. These windows are difficult to get in the adult patient, while in the pediatric we go, most of our anatomy is dependent on the subcostal view. Then LA, and here we get the right pulmonary artery in short axis view. This flap identify left atria, again this is right pulmonary artery. And while you are doing echo here you get right lower pulmonary vein. So at where we are scanning we should get maximum information from that view. Here this is SVC. Near the SVC, as you told, transversus slightly inferior, you get right upper pulmonary vein. Near the IVC you will get the right lower pulmonary vein. So pulmonary veins simultaneously you should look for while you are scanning. You have not to go backward. Okay, pulmonary vein I left, we should look on the pulmonary vein. Here right upper, here right lower pulmonary vein you will get. Then the flap, then again coronary sinus to define left atria, RA, RV. This view is to show offsetting of the AV valve, means this is tricuspid valve, this is mitral valve. LA here, like this is just simple 4-chamber view for you, but it is here information you have to get is the hugely dilated LA and the LV, means any interventricular or the PTA or AP window, some communication is definitely there. You have to just from this 4-chamber view, the information you are getting is the 4-chamber view, normal attachment, no ASD is seen in this view, no ventricular septal defect is seen in this view, but LA, LV is dilated, pulmonary veins are prominent. This is left lower pulmonary vein, which is too dilated, this is too big, and LA is too big. So you have to rule out the septal defect, means if there is no VSD, you have PTA has to be there or AP window has to be there. So LA, LV volume overload is there. So these things should be in your mind, which further step you have to take. Then this is the short axis view to define again. This is the left ventricle, discrete papillary muscle, rough trabeculation, moderator band, smooth on the LV side, intact ventricular septum in this view. Again, dilated left ventricle, papillary muscle to define the left ventricle.
As ma'am told, that not only knowing the morphological structure through the different view, but you should have a proper habits of going through the sequential analysis, and then only your probability of getting correct diagnosis is more. Thank you very much.